Assalamu alaikum. Hello everyone. This presentation I have presented on the CT cardiac course level 1 or equivalent to level 1 at Liverpool Heart and Chest Hospital. It's a brief introduction to beginners to understand the indications and the current applications of cardiac CT. So in addition to the role of the cardiac CT in coronary artery disease, there are many applications for CT, for example, or for instance, assessment of the heart valves, whether the native or prosthetic, congenital heart defects, any vascular diseases, aortopathies, pulmonary hypertension, detection of cardiac masses, and sometimes in cardiomyopathies as well. So let's go through some of these indications. For example, in coronary artery disease, we know that lately or in 2016, the UK NICE guidelines has recommended the use of CT as the first line of imaging. So there is an increased role of cardiac CT in the region in detection of coronary artery diseases, not only in detection of the morphology, but sometimes the anatomy, and there have been also some advances that we will see shortly. Before doing the CT angiography, we know that sometimes we would do a calcium score, which is a native CT without any contrast, in order to see the calcification, yes or no, and also if yes, then how much, because this will guide the management of those cases. Some of the institutes in young patients would do the calcium score. If negative, they will not proceed to the CT angiography. However, if it's positive, then there is a threshold of what's mild, moderate, and severe. So there is a scoring system in order to guide the management and the medication or the therapy. The CT angiography, if we decide or if the team decide to move to the CT angiography, coronary artery or coronary CT, not only to describe the coronary artery, sometimes it's to describe congenital anomalies sometimes, or some of those coronary arteries have an abnormal origin, one of which is the malignant course, where the coronary artery will decide to originate or arise from an area between the aorta and the pulmonary artery. So while pulsation or while at exertion, sometimes they would squeeze the coronary artery, causing chest pains at exertion. Cabbage or bypasses, or sometimes being used for preparation for patients below the 60 years old. So sometimes they would rather prefer to use the CT in order over catheters in order to reduce the radiation for patients. And the increased role is because of course, because of the increased resolution in CT. So we could get detailed description and significance of the plaques, calcified, are they mixed, are they short, are they focal, in order again to guide the management. And also after the management, sometimes with the increase and the improvement in the resolution, after putting a stent, we could see inside the stent if there is re-stenosis, in-stent stenosis, material break of the stent, migration of the or under inflation of the stents. Of course, it will depend on the material of the stent. So the picture quality will depend on the material of the stent, the size of the stent. If it's below 3 millimeter, then it would make the assessment very difficult. Not only that, but sometimes if it's a severe coronary artery disease that led to a myocardial infarction with severe complication, for example, in this case, that is an aneurysm coming out of the left ventricle. So that is a short axis. We could see the right ventricle, and that is the left ventricle with a massive aneurysm. So it could tell us, of course, for surgical guidance, what is the measurements of this aneurysm, the neck of the aneurysm, so description of the neck. Or sometimes the aneurysm includes or is involving the coronary arteries themselves. So the follow-up of those aneurysms is crucial to understand. Is there a trend of increase or not? Sometimes not only the coronary artery disease, but in detection of how far is this coronary from the pulmonary or from landing zones for potential percutaneous solution. So again, that would be important to understand how far the coronary artery from a potential landing zone. Contraindication, among those contraindications, some of them are absolute, some of them are relative. So among the contraindication, I would say if it's an acute myocardial infarction, again, stents below 3 millimeter would make the assessment very difficult. Or severe anaphylactic shocks from the dye or from the contrast, not from the CT, but from the dye itself. Some relative contraindication may include if extensive calcification, but again, if the extensive calcification is distal, it's not in the proximal mid, so some colleagues would still proceed with the CT angiographies. High BMI, because that would be causing a lot of exposure, those are relative contraindication that with the experience and according to the guidelines could be managed individually per each patient. There are many advances taking place in coronary artery disease on CT, for example CT perfusions in order to see and map any delayed enhancement, and sometimes of course the adenosine, if the patient is contraindicated to go for adenosine MRI study because of a pacemaker for example, then CT might provide an alternative. Not only that, sometimes when we detect a plaque or a lesion or a stenosis, moderate one, so sometimes it's difficult to understand whether that is significant or functionally non-significant. So after giving the GTN, CTFR could test whether this stenosis is causing the symptoms and is significant or not, in order to decide and guide later on the management of the patient. When it comes to valves, I think the CT has role in both the native and prosthetic valves. Let's start with the aortic valve, where CT now it clearly is in the guidelines to tell whether there is a severe underlying stenosis, for example, in the aortic valve, or it's not. The calcium score, so for example, in men, likely above 2000 is considered there is likely a underlying severe stenosis, and 1200 in women. 1600, it's most likely an underlying aortic stenosis, severe aortic stenosis, and 1600 in women. So it is important to do sometimes calcium score. Sometimes the echo window is poor and difficult or low gradients, although it seems to be a severe aortic stenosis, but there are low gradients or low stenosis gradients. So the CT calcium score comes in the guidelines and would help to confirm that there is a severe aortic valve, underlying aortic valve stenosis, which requires an intervention. Again, CT here will come and say, and it is in the guidelines now to tell there are certain features that could tell that this patient is feasible for percutaneous solution, or know that this patient or this annulus or this aortic area is not feasible for percutaneous solution and has to go to surgical aortic valve replacements. What are those features? Sometimes are the measurements. So we have the systolic and diastolic measurements in CT, so we clearly can provide systolic and diastolic images and diameters in order to decide, yes, it's too big, has to go for a surgical, or it's too small, again, has to go for a surgical, or no, the size is suitable for the valves that are in the market at the moment. If we move further, it also can describe how the cusp looks like. Is it the normal, which is tricuspid, or is it a bicuspid? We could see that is the left atrium, interatrial septum, right atrium. That is the non-coronary cusp resting at the interatrial septum. That is the right coronary cusp, and that is the left. So it's a bicuspid where the non is attached to or fused to the right coronary cusp through a calcified raphe. And here we could see 4 sinuses, 1, 2, 3, and 4, and sometimes one of them is rudimentary. So all of those could describe, so that could guide for the interventionist in order to decide, yes, it's suitable for percutaneous TAVI, or it's not suitable. Also, sometimes it's poor echo window, difficult echo window, so sometimes it's difficult to measure the aortic valve area. CT here can come and measure clearly and accurately the opening area. So 1 centimeter square and below is considered a severe aortic valve stenosis that requires management. We could see here, for example, that is post-intervention complication, that is before the valve replacement. So we could see the coronary ostium is free and is patent. However, in this case, there is a thrombus at the ostium just after the intervention. Again, native, when it comes to mitral replacement, there are certain measurements that come out from the CT in order to guide whether that is suitable for the percutaneous solution or not. And there are certain angles with certain measurements describing how much is the calcification. Is the calcification going inside the myocardium? We could offline simulate the valve, and whether that valve will obstruct the outflow tract or not. This view is an 3-chamber. We could see that this is the left atrium, this is the left ventricle, outflow tract, aortic valve, and that is the aorta. So whether this new valve, will it obstruct the outflow tract? Will it obstruct the blood coming out from the left ventricle to the aorta or not? And we could describe what is the offset. For example, please put it more in the atrial level than the ventricular level and so on. Also the same, we could simulate in the pulmonary area in order to see whether that is feasible for percutaneous solution, especially in congenital heart anomalies. After having the valves, so prosthetic heart valves, CT also could tell, for example, in the mechanical valves, the opening and closing angles. So it could detect well-functioning valves, or is it a malfunctioning valves? Each vendor of each valve has a certain opening and close angles that have been published in literature. So detection of those angles, comparing it to what is measured on CT, we could tell, and CT can detect whether this is a malfunctioning valve or well-functioning valve. Cardiomyopathies, does it have? Yeah, of course, it could differentiate between ischemic and non-ischemic. So if it's ischemic, we saw the role of CT in coronary artery disease, and if it's non-ischemic, what is the role of CT? It could measure. It could be a good alternative to measure the functions and the volumes of the heart. If the MRI is contraindicated, it could measure, and we saw the advances, it could show delayed enhancement. It could provide an alternative also for adenosine stresses if it's a ischemic case. Not only that, but sometimes it could detect some certain patterns for certain cardiomyopathies. For example, in this case, we could see severe calcification in the pericardium, and that is constrictive cardiomyopathy, leading to constrictive physiology. So, which means that the ventricles cannot dilate, cannot relax properly, which means the atria will see a high pressure, and they will dilate those two atria. Not only that, but also some other complication. For example, in this case, we could see that is the left ventricle outflow tract aorta, but on the right side, that is the right atrium, and that is the superior vena cava. We could see a thrombus inside the right atrium. So post-operative complications. Again, after putting the valve, some of those valves might migrate, or so that they might dislodge, and providing again another communication between the ventricle and the vessel above, which means there is some sort of regurgitation, which is called paravalvular leak. So it can detect paravalvular leak complications and also describe and measure. So it could guide later on whether that could be closed surgically or percutaneously. Also, and for example, in this case, you could see that the replaced valve now shows thickened leaflets, and that is possibly a thrombotic material that is developing on the valves. Not only that, but endocarditis and bacterial complication. Sometimes they would migrate to the lungs or would embolize to the lungs, causing lung infarctions. For example, in this case also, we could see a heavy burden of endocarditis or thrombotic material around the calcified valve, and the patient was experiencing also heart failure symptoms. Sometimes at the puncture site, so that is in the pelvis, we could see at the puncture site a large retroperitoneal hematoma. I remember we had 1 or 2 cases where there have been active bleeding detected on CT. Patient was transferred quickly to the cath lab, and they covered the perforation or the dissection by a covered stent. And please always look at the bigger picture. Some of those patients being referred, we could see lung cancers or an extra cardiac complication that might change the management. Vascular, when it comes to vascular, of course, the description of calcification before intervention, because if it's severe and circumferential during balloon dilatation or during the procedure, it might dissect the vessel. So detection of calcification. Pulmonary hypertension, accurate measurements of the diameter of the pulmonary artery compared to the aorta at the same level, and also sometimes detect the cause. For example, in this case, it's interstitial lung disease. Sometimes it's idiopathic, dilated pulmonaries, but there is no clear cause on CT. In this example, we could see a heavy burden of thrombotic material in the pulmonary artery, and the CT described it in the central, which guided the management that could be removed catheter or percutaneously or surgically. So that is the heavy burden of the thrombotic material has been removed, and that the result after, so that is completely removed thrombotic material. When it comes to sizes, in order to measure for the annulus, the sinus, in order to detect for any aortopathy, then CT, of course, is the accurate and the gold standard to measure it, even if we are measuring it on the non-contrast, sometimes on CT chest for lung screening. Still, CT can provide measurements of the aorta accurately. Pre-operatively, sometimes it's important to check for aortic calcifications in order to guide for any puncture. So for example, in the heart-lung machine, sometimes they would puncture the ascending thoracic aorta from the anterior wall or from the anterolateral walls. So it's important to detect whether there is any calcification in those areas in order to guide. Sometimes in order to guide the percutaneous, we need to check the femorals, how the femorals and the iliacs are. Are they patent? Are they kinked? Are they diffusely or focally diseased? Is it a no-go through the femoral arteries? Sometimes tumors are very small to be detected on MRI. For example, in this case, that is a fibroelastoma on the lower aspect of the aortic valves, or CT can tell us whether it's obstructing an outflow tract or an inflow tract in large tumors, and also metastasis. Congenital anomalies, I think for congenitals I need more than 1 month in order to go through. It's one of my area of expertise, but CT plays a major role in congenital anomalies. There is a lot to say in the congenital. For example, in ASD, that is a simple congenital anomaly. It could see the size, it could detect the anomaly, it could tell that the right atrial dilatation, right ventricular dilatation, and it could tell and guide whether that could be closed percutaneously again or surgically by detecting the size of the rims, whether it's suitable for an occluder or not. Coarctation, we could see, and it could measure clearly the measurements of the coarctation, the segment before, the segment after, and of course the coarctation length and the distance to the origin of the left subclavian. And not only that, any associated anomalies with coarctation, for example, the bicuspid aortic valves or VSDs, partial anomalies. It could detect the partial anomalies where one of the veins decided, that is the left pulmonary vein, decided to go to drain to the innominate or the bridging vein, and that is a supracardiac partial anomalous type. Or it could tell is it cardiac or infracardiac. For example, that is the scimitar on the right side, the pulmonary vein decided to go to the IVC, which is the infracardiac type. Again, before any intervention, pulmonaries, usually the CT can provide an accurate measurements in order to guide that is surgical or is it percutaneous, or there are associated anomalies, for example, associated complications, a stent that migrated from the left pulmonary artery down to the bifurcation of the main pulmonary artery, or afterward or after placement of devices, it can device position, or if there is any thrombi developing at the input or the output tract. Those are some of the references, and thank you.